purpose for describing that is it's a 2-minute video. And in fact, in reality, what I actually needed to see was the alarm signs, what to do and where to go with it. You'd probably do that in about and in a 10-minute GP consultation, spending a minute just to identify and just to be sure about what to do. That scenario was about a patient who's very depressed. And the question was, do I refer the patient and dictate a letter for them to be seen by the mental health services in a couple of weeks, or do I ask for that patient to be seen in the A&E department by the A&E liaison nurses? And the map of medicine was there supporting me to work out what's best for that particular patient. Okay, so let's just go beyond the consulting room and say, well, what else? What does the map of medicine offer beyond the consulting room? Well, remember, since 2004, the copying letters to patients from the DH has meant that all consultants should automatically be sending copies of letters to the patient as well as to the GP. And I'm pleased to say that more and more clinicians are doing that. By the way, just in this room, the clinicians that are here, do you automatically send letters to patients or not? Yeah, there's a few nods there. So step 1 is already happening, where patients are getting copies of those letters. But how useful is that discharge letter or that letter going to be for the patient unless they've got something to compare it with, something that says, this is the standard that we have agreed locally, look at your letter and see how it compares. And so maybe if locally we determined a way of managing a condition such as depression or whatever, then giving a copy of the map of medicine to the patient to say, here's your letter, and by the way, this is the pathway that you're on, may be helpful. Actually, let's save a few trees. Let's not keep printing paper. Why not give them access to the map of medicine so that they can access it themselves if they've got the IT? And before people in the room turn around and say, well, actually, how many of our patients do? National survey shows 70% of households do have access. And because of things like life and workplace and whatever, I think can actually access, and families, of course, the proportion of access. So there's an opportunity for patients to be able to see it. But the question is, well, how are people going to see that record, that map of medicine pathway? Well, map of medicine is available through NHS. NHS Choices is www.nhs.uk. Here is the home page, and down here, if we click on that, then you'll see it says also on NHS Choices, and the second option there says map of medicine can see. That's where patients can access the international version of the map of medicine and be able to see the evidence base for their pathways. So that's one way of doing it through NHS. The other way of doing it is maybe thinking, and by the way, that's the depression pathway that the patients would be able to see, which is very similar to the one I've just used. But the other way of doing it is perhaps you thinking about your own organisation that you work in, and perhaps on your own website thinking about putting a link into the map or particular pathways that you've got. Here's my practice website, and on the practice website we've got a self-care section down there, and in that self-care section there is the map of medicine from which they can access the same pathway. Patients have a relationship with your organisation. If as an organisation you start promoting those, patients will be directed to it, and not just patients but their families too, and the opportunity that gives. Okay, finally, how does the map of medicine support the QUIP process, the quality, innovation, productivity and prevention? Well, in terms of quality, first of all, there's over 350 pathways that are now available. Each of those pathways, on average, has been built over about 800 hours worth of work done between GPs, consultants, nurses, allied health professionals. There's an immense amount of time and effort that's been put in to get that, to get to that point where there is an international pathway. You can use that to then start to localise it and start to say, well, actually, we do things slightly differently here. So it's quality. Not only that, but it's been developed inside the NHS. It actually first the Royal Free, discussions between consultants at the Royal Free and local GPs, and between them and Mike Steen and the team, they started to develop. But it's come out of the NHS amongst clinicians who've driven it. And finally, a really important point here that Mike said earlier, that this isn't about mandating a way of doing things. It's not cookbook medicine, but rather it's to enable the supporting of a discussion that takes place between clinicians, between commissioners and providers, to start to say, how can we improve the quality of care that we deliver? What about innovation? Well, clearly, what it's doing is using IT to bring the knowledge to the masses. And when I talk about the masses, I'm not just talking about the doctors in the room. Doctors, nurses, allied health professionals, patients, and the public. It is the masses. It is for everybody. It is the only solution that's available where that pathway can be seen by everybody, well, both inside the NHS and outside it. It does allow localization, which is really important, because if there are things that you're doing differently here, let's hear about them, let's put them down in a pathway, let's make it available for everybody else to use. You take the point about the drug misuse service, clearly there are things that you're doing that go beyond the map. Let's get into that discussion, let's put it down on a pathway so that everybody can access it. And when I'm talking about everybody, I'm not just talking about the GP in the surgery or the consultant or the clinical assistant in the drug misuse service. I'm also talking about the walk-in centres where these patients turn up. I'm talking about the A&E departments. I'm talking about the district nurse clinic where the patient seems to be going off and the nurse notes that they seem to have a drug misuse problem and starting to wonder what we can do. And in that pathway there'll be information that says this is how we manage the patient, but there may well be also contact details of who to ring if you want to refer a patient into the service. Again, the sort of information that actually we find quite hard to propagate. It is linked directly to the smart card, so you don't need to start putting passwords and things in. As soon as you put your smart card in, you're able to access your local version of the map. And of course, finally, it means that patients who are looking at that pathway can start to experience what quality is. One of the most amazing things I found was when a patient looked at their map of medicine, looked at the care they'd received, and came back to me and said, Dr. Hannon, I've received what the map says. I'm getting evidence-based medicine. For the first time, patients are starting to experience what that quality feels like. What about productivity? Well, instead of us kind of procrastinating over what we might do or not do and not sure what to do, the map helps to direct us, helps to focus our energies and the resources that we've got so that we increase the productivity and we're able to do more with the limited resources that we have. And it is about providing the right information to the right people at the right time and in the right place. It enables commissioners and providers to start that discussion. And most importantly, it also helps trainees who first start or the non-experts amongst us who aren't quite sure what to do to have some idea of what the right thing is. It doesn't prevent the experts who know beyond the map, and in fact we need the experts to go beyond the map and say, actually we want you to go off-piste if you like and do something different, but if you are going to do something different, make sure that you've written in the notes clearly why you're going off-piste so that clinicians, managers and patients can see that you're doing what you're doing. And then finally, what about prevention? Well, clearly by removing some of that uncertainty and improving the quality of care, we are preventing wastage of very, very small, meagre resources that we've got. We want to try and ensure that if you're not quite sure what you're doing, you're thinking about risk factors, you're thinking about things a little bit beyond what you already know, and start to say, are there other areas that we might be able to consider that we could change? For instance, in depression, it says consider occupation. Under occupation, it says think about if this person is a soldier, or a firefighter or whatever, and start to think about, because it might well be that that person has other resources that they can access because of their job that you may not have thought about if you're just thinking about depression and the 10 causes or whatever it might be. And finally, it can also help to prevent poor referrals into the service, but also for the primary care clinicians, poor discharges, because we can start to think about, in terms of the map, what is a good referral and what sorts of factors to put in, and also when a patient's being discharged to sort of say, these are the things that we've done that are included within the map, these are the things that we need to think about. Thank you very much.